Welcome to AETCM, the Emergency Medicine Channel. A 24-year-old female with no comorbidities presented to ER with complaints of left ear pain for the past 2 days. Initial 10-second assessment, airway is patent with no pooling of secretion, gargling, stridor or hoarseness of voice. Patient is able to complete one full sentences.
Okay.
Breathing wise, a respiratory rate of 18 per minute, saturation of 98% with bilateral air entry present. Circulation, pulse rate of 100 per minute with a BP of 120/70 with S1 S2 present. Capillary refill time is less than 3 seconds. Disability, GCS is 15/15 with a GRBS of 120 and exposure, patient is a febrile. So it's a case of 24-year-old female with no comorbidities presented to ER with complaints of earache for the past 2 days, which is gradually progressive, worsening into 1 day. Patient had given a history of swimming in a pond prior to this onset of pain.
So you're talking about otalgia right now.
Otalgia.
What are the types of otalgia?
There are 2 types of otalgia, which is primary otalgia, that is due to the pathology in the ear.
Ear itself.
And second, referred otalgia, that is due to the it's a referred pain. That is any injury or any areas involvement of 9, 10, and 5, 7, 9, and 10th, along with cervical plexus. If it involvement,
right.
They refer
Correct.
the pain to the ear.
So it can be dental abscess. Can be multiple issues. It can be dental abscess. It can be retropharyngeal abscess. Anywhere around that area can lead to referred otalgia as well. In this patient, we know that it is direct.
Primary.
Yeah, right.
There is no history of fever, headache, vomiting, sore throat, and altered sensorium. There is no GI or GI manifestations like loose stools, hematemesis melena. There is also no history of blurring of vision or tinnitus in the ear, like ringing sounds of sensation in the ear.
Okay.
So on physical examination, patient is conscious oriented with a pain score of 8/10. So we managed pain initially with the injection PCM was given. Then other systemic examination was within normal limit. So external examination of the ear, on the left ear as compared to right, the ear and pinna appears to be erythematous. Redness was there along with tragal tenderness. Tragal tenderness is elicited when we press on our tragus. Patient will have severe pain. It's more suggestive of otitis externa.
Okay.
So as compared to the left, we can also find there is mild discharge from the ear can be elicited. Patient also complained that she found yellowish kind of discharge in the pillow when she was lying face down.
Okay.
So on the external orifice, we can see mild discharge along with crusting can be seen.
Okay.
So we did otoscopic examination. Examination show erythema of the external auditory canal along with crusting and mild purulent discharge. But tympanic membrane appears to be normal with cone of light also present. There is no perforation.
When you do the tympanic examination, when you do an otoscopic examination, how are you supposed to manipulate the ear so that
ear should be pulled upward and laterally,
backwards, upwards, and medially. Yes. Okay.
That to keep the external auditory canal in straight.
So external auditory canal, how is it composed of?
Usually it's more like a outer 2/3 cartilage and inner 1/3 is bony with a usually an S-shaped external auditory canal. To make it straight, we pull that.
Do this maneuver. Now, one of the main reasons why otitis externa happens is because of the inner bony layer, which is very thinly adherent to the skin. So if you do any kind of manipulation there, the skin erodes faster. There are chances of infection penetrating real fast. Right.
So we also we asked the patient about the like conductivity, like earring dose as compared to right side. Patient is complaining of mild decrease in earring dose. So Rene's test and Weber's test can also be tested in this patient.
Should be done.
So in case of Rene's patients, Rene's in the left side is mildly side is negative. That is when we use the tuning fork of 512 to
Hertz.
512 hertz, and when compare the bone conduction and air conduction, bony conduction is more than air conduction in the left ear of this patient. So which suggestive of Rene is negative, that more suggestive of conductive hearing is.
In this case.
So with the history and our physical examination, we came to a diagnosis of otitis externa of the left ear.
Okay.
So it remains positively. Conductive hearing loss is more in externa due to the debris blocking the external auditory canal, causing the conductive
hearing loss. What is the natural protective mechanism of externa to prevent infections?
So externa is covered by skin, which secretes sebaceous, which also have sebaceous cysts, which secretes.
So there are sebaceous glands and apocrine glands, which would give it secretions. Yes, and cerumen is right.
Cerumen is acidic in nature, which will prevent any infection.
Microbial growth, right?
It will also have antimicrobial properties.
So if you remove a lot of cerumen, also that can lead to the pH being disturbed.
Otitis externa, which is the infection and inflammation of external auditory canal and auricle, which are mainly two types, that is acute diffuse otitis externa and malignant otitis externa.
Okay.
In acute diffuse otitis externa, the predisposing factor is trauma to the skin of the external ear, as well as elevation in the pH, that is the acidic pHs get replaced with basic pH, and mostly seen after contaminated exposure to contaminated pools or swimming pools. Most common organ, so it's also called swimmer's ear.
Yes.
So most common organisms are Pseudomonas, Staphylococcus, Staphyloepididymitis, or Enterobacterius. So even fungal otitis externa can also occur, which is called automycosis, which is mostly caused by Candida or Aspergillus, which is more common in tropical climate immunocompromised patients or patients with history of long-term use of antibiotics.
So if you see fungus, you should be able to analyze the immune status of the patient as well. That should be always kept in the back of your head when you see a fungal infection there, right?
So non-infectious causes are also there for otitis externa, which include contact dermatitis from topical medications or resins in the hearing aid, and seborrhea or psoriasis.
Right.
So most common complaints of patients presented with the otitis externa are pruritus, pain or tenderness in the external ear, and signs include edema of the external ear, which can also spread to auricle or trachea. Then there will be purulent discharge from the ear and crusting of the external ear. There will be intolerant in case of severe disease. There will be intolerance even with mastication, and this increased edema as well as the debris can cause narrowing of the lumen of the external canal, causing hearing impairment. In severe cases or immunocompromised patient, the spread of infection to the periauricular soft tissue as well as cranial nerves can also involve, and lateral protrusion of auricle can also be seen in severe cases due to secondary inflammation.
Right. Why is external ear infections given a lot of importance? And if this patient, throughout the course of the disease, she didn't go to the hospital and it kept on increasing, and the patient has some kind of focal neurological deficits right now, what would you expect?
We have to think for thrombosis,
Very good.
Sigmoid sinus thrombosis or lateral sinus thrombosis. We have to due to that connection between veins. Like external ear is drained into posterior auricular vein, that which in turn drain into external jugular vein. So external posterior auricular vein also have a connection to the sigmoid sinus.
Yes.
So this can cause thrombosis. In case of severe infection it can cause thrombosis to sigmoid sinus.
Most commonly seen in immunocompromised individuals, but yeah, yes.
Treatment include analgesia, then cleaning of the external ear, and also acidification of the that external ear.
Right.
And topical antibiotics can be used with or without steroids. Mostly used as fluoroquinolones.
So one thing that we should make sure before you administer anything is to see if there is any tympanic membrane perforation or not, because some antibiotics cannot be used. Some antibiotics can be used with or without steroids. Right. Go ahead.
So in case of involvement, in case of patient is presented with fever or there is periauricular extension of infection, we have to also add oral antibiotics to the patients.
Right.
In fungal, in case of fungus is the cause of organza, we have to start or topical antifungals like clotrimoxazole 1% solution along with antifungal agents. And we will ask the patient to follow up in ENT OPD to review after 1 week. Or to come to ER in case of excessive in pain or swelling of the external ear or external ear or external ear.
Yes.
So there's another
Component of
otitis externa, that is malignant otitis
life-threatening malignant otitis externa, which is mainly caused by what organisms?
Pseudomonas aeruginosa.
Nowadays, what is being again coming into the picture along with Pseudomonas
MRSA.
MRSA.
So the persistent infection of external ear, even after 2 to 3 weeks of antibiotics, we have to suspect malignant otitis externa, which is more common in diabetic patient and immunocompromised patient. This is an infection of external auditory canal with pinna, as well as spread of infection to the soft tissue, periosteum, cartilage, and bone.
Yes.
MRSA, some fungus can also cause external otitis media. So patient mostly presented with otalgia with edema of the external auditory canal. On examination also there will be erythema with the granulation tissues present. In case of if the patient is presented with trismus or parotitis, we have to suspect that the masseter muscle as well as tympanic joint is also affected. Like cranial nerves can also affect. Most common cranial nerve affected is 7th nerve. Later to 9, 10 or 11 can also affect. Complications include sigmoid or lateral sinus thrombosis. Meningitis is more associated with malignant otitis externa. Treatment include is IV antibiotic. More commonly fluoroquinolones like ciprofloxacin can be used. If the patient is presented to us in a sepsis stage, we have to manage according to sepsis protocol. So our patient, since we have a left otitis externa, we started on cleansing agent. We started along with topical antibiotics. We even given ENT consultation. They started on topical antibiotics along with ear plugs were also, ear wigs also added to the patient.
Okay.
And ask the patient to review after 3 days in the ENT OPD.
All right.